Okay, Assalamualaikum and good evening, everyone. This is the fourth session of CME brought by MedTweetMy, and for tonight, our guest speaker is Dr. Sazwan Reezal, consultant in emergency medicine, and our topic is chest pain assessment. This is a very important topic, so I hope you can still share with your friends and colleagues about this session so that they can join via Zoom or if not via Facebook Live. I'm Hafsa. I'm one of the chairperson of CME MedTweetMy, and we have our co-chairs, Dr. Rafida and Dr. Iskandar Mirza with us tonight as well. And we also have our committee members. I'll list all of them. So we have Dr. Afida Sohana, Dr. Anwar Fazal, Dr. Nurman from UKM, Dr. Nurul Yakin, and Mr. Zainal Adwin. We also are collaborating with UKM for the promotion of this event. And sorry, can everyone make sure that their mic is mute and make sure you don't.
After unmute your mic, sorry.
Okay. So we welcome any questions. You can type it on Zoom or on Facebook Live. And I would like to stress that we will not comment on any specific cases of patients. Okay, so please do not share any patients' cases on any of these platforms. So Dr. Sazwan, are you ready?
All right, I'll share my lecture.
So without further ado, I would like to invite Dr. Sazwan Reezal.
All right, thank you, Dr. Alsa. Thank you, MedTweetMy, for the opportunity. Today, I would like to share with you an approach to the chest pain and to chest pain. And this is the objective of my lecture. I was talking about the anatomy, some pathophysiology, the risk stratification, followed by the life-threatening conditions, how to tackle these life-threatening conditions, and the stepwise approach. All right, so we start with this scenario first. The scenario number one is a 40-year-old male, background history of diabetes and hypertension for the past 5 years, complaint of central chest pain for the last 2 hours. It's heaviness in nature, non-radiating, associated with nausea, sweating, and this is his first episode. Another case, a 52-year-old female, post-op day 3 total knee replacement, a complaint of central chest pain associated with breathlessness and sweating. And in front of the nurse, she's coughing out streak of blood. So I hope by the end of this CME, all of us might have some idea how to approach this type of cases. All right, so we start. The picture signifies eyes can't see what mind doesn't know, kan? So if we don't have the idea, definitely even the elephant in front of us, we can't recognize. So the working diagnosis will be the life-threatening. I will only share the life-threatening conditions. It's cardiac and non-cardiac cause. First is acute coronary syndrome, ACS, pulmonary embolism, thoracic aortic dissection, pericarditis, pneumonia, perforated peptic ulcer, pneumothorax, and esophageal rupture. So we start with the anatomy. If you notice, the heart is actually not really totally on the left. It's actually majority of the left ventricle is situated behind the sternum. And that's why in CPR, we advocate that we put our hands on the lower half of the sternum. If we see in this picture, it signifies the left ventricle. And if you see, the apex of the heart is located between fourth intercostal or fifth intercostal space. And that's why we don't need X-ray to diagnose whether patient have cardiomegaly. I also would like to emphasize on the layers of the heart wall, because in certain conditions, like cardiac tamponade, the fluid will accumulate within the walls. All right. So let's talk about the pain. There are two types of pain fibers. The first one is the somatic pain fibers. Usually it's a dermis and parietal pleural innervations, and it enter the spinal cord at the specific levels and arrange in a dermatole pattern. And pain is usually easily described. Usually patient can localize the pain, and usually the patient will describe it as sharp sensation. All right. Whereas another one is the visceral pain fibers found in the internal organs such as heart, esophagus, and the blood vessels. This is more non-specific. Usually, patients can't really localize, difficult to describe, and this is where the challenge is, because the patients have difficulty to localize and to describe, but actually the pain might come from the major organ, especially from the cardiac. And there are also some modifying factors to the pain sensation, such as if you are elderly, some medication, drugs, alcohol, and sometimes the different in cultural and the language differences also make the doctors have difficulty. Like in my experience in HUSM last time, every pain, chest pain is sekak. Indigestion, sekak. Everything is sekak. And kenaling is actually means palpitations, but sometimes they interchange using it. So it's quite difficult to differentiate what's really the patient's meant.
I think, sorry, Dr. Sazwan, to interrupt, but I think not a lot of people know what sekak is. If you can just briefly explain.
Oh, sekak. Sekak in Kelantan means pain. Really, they refer to chest pain. Sekak. Kenaling is palpitation. So like non-Kelantanis like myself, we do have problems. That's why for doctors, every time you go to a new district, new hospital, you might to mingle with the culture and the language. All right. Okay. Then there are also special group who can present it with chest pain, but they did not report it as chest pain. This we call a group with atypical chest pain. They might present it with only with sweating, or only with jaw pain, or only with lethargic, but actually in reality they are having chest pain. This group, especially the elderly, I'm not sexist lah, but it's written there, female, diabetic, and mentally challenged. This is another issue. Mentally challenged means patients like schizophrenia. Sometimes they aggressive, but actually they are having chest pain, right? Okay, let's go to the gist of my presentations. Chest pain equals to acute coronary syndrome, ACS. I don't really like using the ACS because ACS can mean from unstemi angina or maybe non-stemi and stemi, because it can be either one, and the treatment is actually quite different, and the aggressiveness is also different. And once we diagnose patient having acute coronary syndrome, whether it's unstemi angina, non-stemi or stemi, time is running, because time is myocardium. The later we act, if you keep thinking this patient might have or not really, so actually you allowed the heart cells infarcted or become necrosis. look around. If you are staying with your family, look around in your house. These are the people who are at risk to get acute coronary syndrome. Those are aged more than 40, male, hypertensive, uncontrolled diabetes, uncontrolled, hypercholesterolemia, smoker, and a strong family history of IHD. All right. Let's talk about the pathophysiology of ACS. Usually, normally we think that our cholesterol, the cholesterol, causing obstruction. Actually, it's not directly, it's indirectly. So when there is plaque rupture or erosions, it attracts your thrombus to be developed, and this causing, if it's total occlusion, it's called STEMI or ST elevation MI. If it's partially occlusive, it might cause unstable angina or non-STEMI. All right, and the effect on the ECG is quite abrupt. It means that within minutes after the infarction, there will be alterations in the electrical potential, which can be seen in ECG as the ST elevation, ST segment elevations. All right, let's talk a bit about the coronaries. And tonight, I'll give you some tips so that in the future, when you do rounds with your specialist, you can tell your specialist, oh, this patient having STEMI due to right coronary artery blockage. Okay, how we are going to do that? Okay, if you still remember, this is our right coronary artery. This is the marginal branch, and this is the left coronary artery. And down here, there is the diagonal branch, and this is the circumflex branch. Okay, if it's blocked on the right coronary artery, so it will affect the inferior 2, 3, and AVF. If it's blocked, the left anterior descending coronary artery, it will cause ST elevation at V1 to V4, and if it's blocked at the circumflex branch, it may cause ST elevation at 1 AVL, V5, and V6. With this knowledge, I'll share with you an ECG later, but this summarizes what ACS is. So basically in ACS, the most important thing is the history and the ECG. The cardiac biomarkers is not really needed immediately because ST elevation MI does not need to have positive cardiac biomarkers. I will tell you later why. All right, and this is the likelihood that signs and symptoms represent an acute coronary syndrome. Okay, so you need only 4 components: history, examination, ECG, and cardiac markers to diagnose if somebody is having acute coronary syndromes. Other patient is having unstable angina, non-STEMI, or STEMI. First, from the history. If the history is, we call this is a typical chest pain history, chest or left arm pain as chief symptoms, reproducing prior documented angina, and if the patient known history of coronary artery disease, including MI, from the history itself, it's very high likelihood patient might have acute coronary syndrome. And if patient have hypotension, diaphoresis, pulmonary edema, or crepitations, of course, this will support. And if there is ECG changes with elevated cardiac markers, so this is high likelihood that patient presented with acute coronary syndrome. All right. However, I would like to emphasize that normal ECG does not exclude acute coronary syndrome. Okay, again, normal ECG does not exclude acute coronary syndrome. Normal cardiac markers does not exclude acute coronary syndrome. All right. Okay, let's go and have a just a peep. We should have a full CME on ECG, maybe in the future, but not me. All right. So STEMI is diagnosed when there's ST elevation. Okay, just to recall, this is the ST segment. When there is elevations more than 1 mm in two contiguous leads, it's considered as STEMI, of course, with the history and the physical examination. Okay. How we compare that? We compare that with the isoelectric line of the PR segment. So if the ST segment is above, the PR segment is considered as ST elevation. And a new onset of LBB. Okay, a new onset of LBB, we don't know whether patient is memang dah ada LBB or patient previously already have LBB, or is it new? But I would like to introduce to you the Scabosa criteria. Sorry, the Scabosa criteria will help you in make a decision whether the presence of LBBB in a patient with chest pains is considered as STEMI or not. All right, and yes, from the history and in STEMI, the cardiac biomarkers will be positive. All right. So what do we have here? All right. So when we have patient with chest pain and ECG, we have about 10 seconds to make a decision whether is this a STEMI or not. So what do you think? What obvious here? What's obvious here? There's if you can see, there's ST elevation at V2, V3, and V4, and you can see also at the lead 1 and the AVL. Okay, so based from our anatomy, where's are the blockage maybe? All right, so it's almost higher up in the left coronary artery, causing the ST elevation in V1 to V4 and lead 1 and AVL. All right, so this is not good for the patient. All right, I'll talk a little bit about unstable angina and non-STEMI. Patient having prolonged ischemic chest pain more than 30 minutes and having a normal ECG or ST segment depression may either have unstable angina or non-STEMI. So what makes unstable angina and non-STEMI different is only the cardiac markers. And these are the short-term risks of death in non-fatal MI patient with unstable angina and non-STEMI. That's why it's very important for us to catch patient who presented with unstable angina, because even though patient might look comfortable, but there will also increase of risk. So if patient having unstable angina and we did not treat the patient properly, we might see the patient back come to us with full-blown STEMI. All right. Okay, let's talk about cardiac biomarkers. I'm not a fan of cardiac biomarkers in chest pain because of few things. Number one, STEMI, which is life-threatening condition, should be diagnosed without the cardiac markers. And our troponin is the most sensitive, but it only start to pick up after 4 hours. And sometimes our patients come earlier. Okay, and CKMB was previously the gold standard cardiac biomarkers. It is relatively specific, but sometimes if patient have like say IM injections or just few hours come back from massage, the CKMB might raise, even though it might not caused by the myocytes. And myoglobin is not that specific, but the good thing is it may elevate in 2 hours. But now with the current technology, we call high sensitivity troponins, which may elevate as early as 30 minutes after the onset of chest pain. But again, I feel that we should be able to diagnose STEMI or unstemi angina or non-STEMI without the cardiac biomarkers. Okay. So I just share with you. After this, you can have a look. I will share with you this slide in the slide share later. Okay. This is the scoring we use to risk certify the possibility of or increased mortality in unstemi angina or non-STEMI. All right. Okay. TikTok is not the TikTok you dance lah. It's just to emphasize that time is myocardium, and you should act as ASAP. All right. So set IV line, give oxygen if the saturation is less than 95, put patient on cardiac monitors, do ECG stat. By stat means immediate ECG. All right. And usually we should address the life-threatening threats systematically away breathing circulation. I will not going specific on this. I just want to highlight the importance of giving aspirin in patient you diagnose having acute coronary syndrome. And on top of that, you may add on clopidogrel, and to relieve the pain, to me sublingual GTN will serve the purpose. Okay. Next is, just now I talked about time myocardium. What does that mean actually? Even in the treatment, if patient come to us less than 3 hours with ST elevation MI or STEMI, wherever patient arrive, primary PCI or fibrinolytic therapy is a preferred option. Okay. So meaning the best treatment for those patients who come early is primary PCI and or fibrinolytic therapy. But if patient come quite late, the best treatment is primary PCI. But in my hospital, we don't have cardiologists, and the next cath lab is about 120 kilometers away. So the best second option we offering patient is the fibrinolytic therapy, kinase or dermatalis. And if patient presented to us more than 12 hours, there is no role of fibrinolytic therapy. Patient should be referred for primary PCI. And this is the STEMI risk score for predicting 30-day mortality in STEMI. I just want to emphasize why we should jaga BMI, not just for us, for our patient, because in these categories, the only things that we can modify is the weight, the BP depends, but then the history of diabetes, hypertension, and our role here is time to treatment. Okay, so that's why we need to give early treatment, so that we help patient to reduce the risk of 30-day mortality. Okay, next is pulmonary embolism. It is a blockage in the pulmonary arteries. Thrombus originate in the deep venous system of the lower extremities, such as DVT, and just want to refresh back the Visceral triad, and the decreased blood flow causing stasis, damage to vessel wall, and hypercoagulability. This is the Visceral triad and causing the DVT. And what are the risk factors for PE? Recent surgery. So patient in surgical ward, patient in orthopedic ward, patient in obstetric and gynae are the good candidates for pulmonary embolism. So those are working in on those wards, please be alert for this. And other risk factor, advanced age, obesity, immobilization, taking estrogen containing OCP, smokers and cancer patients and infection are also high risk for pulmonary embolism. All right. And the symptom is chest pain, but it's pleuritic. Pleuritic means when patient breathes in, out, he or she is having pain. And the patient will feel breathless, and sometimes they might coughing out blood, hemoptysis. And clinically, patient appeared tachypneic, tachycardic. SpO2 shows low oxygenation, and in severe form of PE, the BP might be low. And this is the Wells score for PE. So if you have patient and you suspect patient have PE, you calculate. So that will give you idea of whether patient are at the low risk, intermediate risk, or high risk, because pulmonary embolism can kill. So how you diagnose PE? In what? Of course, gold standard is by CT angio, but the easier investigation we can do is doing an ECG. And in pulmonary embolus, basically, the changes are towards the right side of the heart. There will be RBBB, okay, right ventricular strain pattern, as evidence of inverted T at V1 to V4 and the inferior leads. You can see lead 1, lead 2, if you sum up, it's right axis deviations, and you might able to see S1QT3 pattern. This is famous, but actually it's quite, from my previous experience, patients with PE only come with right axis deviations and tachycardia. These two are more important, but if you have evidence of S1QT3, it's a bonus. All right. Nowadays, we are talking about point of care ultrasound. I have just showed to you, this is the normal short axis, and this is your left ventricle, this is your right ventricle, and your right ventricle is crescent shape, and your left ventricle is rounded. But in pulmonary embolus, there will be a D shape in left ventricle because there is increasing of pressure in the right ventricles, and the size of right ventricles is increasing. Okay, of course we can do chest X-ray, but Westermarck signs and Hampton signs I found out very quite difficult for us to appreciate. And of course, CTPA and VQ scan is the diagnostic. However, most of the patients can't lie down in the CT room. All right, so we might have problem with that. Okay, and the treatment will be anticoagulations and thrombolysis if patient have hemodynamic instability. And in centers with intervention radiologists, they can do thrombectomy, or if not, we need help from our surgeons. All right, next. Oh, almost 9. Thoracic aortic dissection. Okay, this is your healthy wall. In thoracic aortic dissections, there's the rupture of intima and dissection in the tunica media. So patient will have severe chest pain, and they might describe like, doktor kena koyak, okay, dada kena koyak. So think about that, and usually it can the chest pain is may radiate until the neck or the jaw, and sometimes radiate to the back. The pain might be felt in the intra scapular area, and patient might syncope or presented mimicking CVA. They might have dyspnea and hemoptysis. Okay, so the clinical signs are the BP would be high initially, but if no action was taken, and the BP will becoming low, and unrecordable. And you might also want to measure the interarm blood pressure, because there will be some difference, white pulse pressure and tachycardia. All right, and the chest X-ray might give you the suspicion that patient might have thoracic aortic dissection as evidence of the widening mediastinum. And what is widening mediastinum? If it's in AP view, it's more than 8. Or if you look at the X-ray and you tell yourself, hey, the mediastinum looks widen. Betul lah tu. It's a widened mediastinum lah. All right. So of course, if patient can go to the CT room, CT with contrast will be a good modality to diagnose. And for us, we can give analgesia to relieve the pain and start infusion of beta blocker like labetalol to reduce the BP, and goes to our vascular surgeon. Next, pericarditis is inflammation of the pericardium. Symptoms is pleuritic chest pain. Patient might having fever and preceded by cough or sore throat before the chest pain. And because there are a lot of causes of pericarditis, we also need to know, we might need to get some history of the causes. All right. And ECG and pericarditis is a widespread ST elevation. Widespread. In some books, it described as saddle, saddle shape. I'm not a cowboy, so. But for us, important to differentiate pericarditis with extensive MI. How can we differentiate that? Number one is, of course, from the history. Number two, if there is an ST elevation and PR depression throughout the most of the limb leads, 1, 2, 3, AVL, AVF, and if you look at the AVR, there will be a ST depression and PR elevation. So it gives rise to you, suspicious to you that a patient might have pericarditis. Because the treatment of pericarditis is not the same with acute coronary syndrome. And what are other modalities which might help us in diagnosing pericarditis? Again, point of care ultrasound, pericardial effusions. Okay, this is your left atrium, left ventricle, right ventricle, and this is your normal pericardium. All right, and this is the fluid, which is signifies pericardial effusion. If you have patient with that type of ECG with pericardial effusion, ask yourself whether this patient is having pericarditis. Okay, I have to go faster. Pneumonia, fever, cough, shortness of breath, and what do you think about this X-ray? It looks like COVID-19 pneumonia. All right. Perforated peptic ulcer, usually patient might have history of peptic ulcer, history of ingestion of NSAIDs and intermittent epigastric pains. Patient may have lower sharp chest pain extending to the back, to the shoulder, and it may start from the epigastric region and pain worsened by movement. Patient might be pale, hypotensive, tachycardia. If you examine the abdomen, it might be tender and guarded, and the erect chest X-ray might show air under diaphragm. And this is air under diaphragm. All right. Next, pneumothorax. Okay. Sorry. So pneumothorax, because rupture of blebs and bullae, the risk factor for spontaneous pneumothorax are smokers, those who are thin, tall, muffin syndrome, patient who is pregnant and having history of familial pneumothorax is at risk. And the symptoms, again, chest pain with difficult to breathing, patient might be tachypneic, restless, low saturation, hyperresonance on percussion, reduced entry, and the trachea should be central. If it shifted, it signifies tension pneumothorax, which is also another life-threatening condition. So can you appreciate the thin line? So this is the lung markings. So this is the right pneumothorax. All right, esophageal rupture, basically from history, sudden onset of chest pain after forceful vomiting. And from the chest X-ray, you might see a lot of subcutaneous emphysema. And if you can appreciate this, surrounding the heart, there are casts. And so this is medium mediastinum. So if you have this X-ray with the history, so you suspect esophageal rupture, and this is the stepwise approach. So first, when you have patient with history of chest pain, immediately do ECG. Cannot wait. Even the nurse can perform ECG while you are taking history, and you're taking history of the chest pain, the character of pain, whether it's radiating or not, and you do risk stratifications. And next, you take the vital signs and the physical examination. So during the physical examination, you must elicit where the patient is pale, how the pulses, if is patient in failure, how about the lung? Is there any evidence of pneumothorax? And don't forget to examine the abdomen. And next is the ECG interpretations. Is it ST elevation MI or not? Or is it pericarditis or whatever? All right. And after you have the ECG, you might need to start and initiate treatment without waiting much time. Okay. The next is the chest X-ray. Do the chest X-ray interpretation. And if you have the ultrasounds or you have the skills, use focus to help you in make diagnosis. Okay. After that, you can continue with your diagnostic investigation, whatever CT you want to perform after that, and other lab investigation. So yes, 9-8 minit. Sorry Hafsah, terlebih masa. I will share my slides in slide share. I will share the link in my Twitter later. And those who are interested in point of care ultrasound, you can check this website, www.criticalultrasoundmalaysia.com, because this is the society who are actively organizing point of care ultrasound courses. Okay, with that, thank you.
Thank you very much, Dr. Sazwan. I have learned a lot from your presentation, but I would be confident that the participants out there would agree with me that chest pain assessment is very important. We deal with it every day in emergency department and the rest of the medical, the rest of the settings in hospital or clinics. You know, you can come across chest pain as a case anytime, and you should be able to deal with it confidently. And before we close up, I would like to give the floor to Dr. Iskandar to moderate the question and answer session.
Okay, thank you very much, Dr. Hafsah. Okay, quite interesting. Now we have a lot of questions from the audience. Okay, so are you prepared, Dr. Sazwan?
Shoot me.
Should be okay. Okay. Now we go for the first question from Miza. Hi, I'm just wondering, for the group with atypical chest pain, are they mistaking their chest pain with some other pain, or they classically do not usually present with chest pain? Thank you.
Sorry, come again.
The question will be for the atypical chest pain.
Okay.
Are they mistaking their chest pain with some other pain, or they classically do not usually present with chest pain?
Yeah, actually, the answer is B. They are usually not presenting with chest pain, but actually the origin of the pain is the chest pain, the causes of chest pain.
Yes.
So as I
So,
shared, sorry.
okay. So usually for this kind of question, actually they don't present with a typical chest pain, means that the compressing in nature. So what they will present with usually is sudden shortness of breath, and this one feel uneasy over the epigastric pain. So this is one of the type of the atypical chest pain.
Yeah, sometimes
However,
they just
yeah,
presented with lenguh tangan kiri
yes,
or lethargy.
yes.
But when we do ECG, we found that there is ST elevation.
That's true. So for the second question from Haikal Huzaifi, do we use old Scabosa or modified Scabosa Criteria now for LBBB?
Okay, now we can use the modified Scabosa.
Okay,
Actually,
yeah,
not much different. As long we can differentiate the scoring, it should be okay.
okay, okay. Thank you, Dr. Sazwan. So the third question from Afifa Asri. Doctor, how about the ECG shows there's a T inversion and ST elevation? Does it mean patient have both IHT and MI?
Oh, in the same lead.
Yeah, actually it's impossible to have
Yeah.
ST elevation and T inversion.
But what I think what she means is the reciprocal changes. I think what she
Okay.
means the reciprocal changes, which you see ST elevations in let's say the anterior leads, but you see ST depression at the 2-3 AVF. We call that reciprocal changes. And another thing is when an area having infarct, maybe other area might be affected as having ischemia. So that might be another hypothesis lah.
Okay. Okay. So the next question will be from Nur Kaya. Assalam doctor. In
Salam.
clinical setting, is it significant to differentiate between somatic and visceral chest pain? Thank you in advance.
Usually if patient having somatic chest pain, actually while we are working, we are not thinking whether is it somatic or visceral. Chest pain is chest pain. Just if patients having difficulty to point or to quantify or to express how's the pain like, actually we should be more worried rather than patient can show with 1 point. Okay, but at the end we take all chest pain seriously.
Okay, that's true. So remember Nurkai, so if the somatic one actually is like is both a chest pain. However, the somatic one is not the cardiac. Usually, it's not the typical cardiac lah. While the visceral is a typical cardiac. But in a ED setting, you have to do everything. No, sometimes patient present with atypical chest pain also, just like what Dr. Sazwan said. So every chest pain need to be treated seriously in the ED setting. Okay, Dr. Sazwan, the next question from Nuril. Salam, doctor. Is there any reason why we use funda in STEMI and enoxaparin in non-STEMI?
Is yang ni kau kena jawab lah Is.
Okay, actually there's no reason why not to use both funda. Depends on the renal function. This one, if you want to refer Dr. Rafida also can. If you want to, whether you want to use funda or enoxaparin. For those who have EGFR of below than 30, so we prefer to use enoxaparin compared to fundaprinox because it's very difficult to excrete from the kidney. So by right, you can give both, but fundaprinox is easier because once a day. Okay, Nuril?
Take care of my patients.
Okay, so the next question would be from Nur Fazrin. Salam doctor, is there any role for analgesic or GTN for patient with PE in acute setting? Thank you.
Okay, for PE GTN, no, because the problem is in the pulmonary artery. It's not in the coronary artery. The nitrates helps in when you're having blockage in the coronary arteries. So nitrates is not suitable for pulmonary embolus. But then you need to make patients, you need to give analgesia. Maybe morphine might reduce the pain. However, it does not relieve the cause.
Yes, it's true. I agree with Dr. Sazwan because why GTN there's no study for patient yang the normal patient all done under human under what we call this under animal studies. However, it's not promising because why patient will present with hypotensive also. If you give GTN, further worsen the hypotension. So we don't give GTN in acute setting in pulmonary embolism. Okay, so next question from Nurul Syahira. Good evening, doctor. In PE, banyak pula question PE ni. In PE,
sebab diorang semua jaga ward ni, semua dah takut dah ni.
In PE, if a patient cannot lie down for CTPA, then how to overcome it? Or other alternative way for the diagnostic investigation of pulmonary embolism?
Then we go history, the ECG and the point of care ultrasound. But most of the time, patient with PE, you might need to intubate because they are hypoxia. So if patient is intubated, then you can send them for CT.
Yes.
But isn't it kalau nak mencelah ni, kalau
boleh.
PE, it shouldn't be. Why would somebody with PE just cannot lie down? You know what I mean? Heart failure or pulmonary edema, you will understand kan? Unless they are very ill, they are desaturating, then you need to intubate first lah. In this situation, you probably have to treat clinically first, stabilize the patient first, treat, and then later on only send for imaging kan?
Yes, that's true, doctor. Okay. Okay, the next question from Fazrin again. Salam doctor, if we have a houseman encounter patient with PE, what should we do before informing our MO? Thank you.
Firstly, tengok MO tu garang ke tak garang kan. No, just joking. Okay, first you give supportive treatment first. A patient usually in PE, they are hypoxic. So you give oxygen. But you need to inform your MO ASAP. Better if you inform your specialist. All right, because PE is very, very little and very life-threatening. Because sometimes you need higher authority to make decisions whether to hypernize or to thrombolyze the patient.
Yes, it's true.
Okay, as you know, you can tell your MO lah. So the scoring is this. You dah cakap scoring tu, dia mesti cakap okay punya.
Yeah, it's true. So we can use the well score for the PE. It's quite easy to calculate. Okay. So next question from Sodium. This guy put his name Sodium. So is it common to get pericarditis after COVID? And if they get pericarditis after COVID, is the treatment gonna be the same? Hello? Yeah, it seems that Dr. Norman connection a bit lacking. Okay, never mind. Dr. Sazwan, can you hear my question, Dr. Sazwan?
Boleh.
Okay. So do I need to repeat the question?
About the COVID patient with pericarditis?
Yes, true.
Yeah, I personally I have no experience, but the treatment will be supportive because of the COVID-19. Basically, we treat the COVID-19 and we treat the pericarditis as an inflammation lah. Okay, so I presume NSAID and steroid might help in COVID-19 pericarditis, but depends on the patient's situation condition as well. What do you think, Is?
Yeah, actually your answer is I agree with your answer, Dr. Sazwan. Because why the treatment? Because now we thinking of a viral pericarditis. So the treatment will be the same as a usual one. Steroid, you can use colchicine, you can use high dose aspirin, and other medication will be the same. Unless that you think the pericarditis because of the other causes such as TB or malignancy, then you will be a bit different the treatment. So so far it's not that common to get a pericarditis after COVID, but it can happen. Okay. Okay. So the last, not the last question lah, but this one is a bit from your colleague, doctor, from Dr. Rafida. So you
Asal dia tak PM
mentioned
tepi je ni.
you you mentioned that ECGs need to be interpreted quickly. I believe this is true for STEMI. However, I have seen clinical history was not taken properly to ascertain the diagnosis of unstable angina. Sometimes patients don't have chest pain. How common is the atypical chest pain? Isn't the most common thing occur more commonly still? May I have your comment?
I have no comment. No, I think sometimes there is discrepancy when we are taking history. Depends. Let's say, like Dr. Rafida, when patient see Dr. Rafida, they want to talk more about their kidney rather than their chest. I presume. No, okay. No, I think number one is because of communications. How the doctor ask question, how the patients understand the questions and respond to it. So yeah, that's my comment.
So I would take the history taking is very important, right?
Yeah, very important.
Yeah. A lot of people forget that, just look at ECG but not the patient or talk to the patient. Just a comment.
Okay. So quite hot question, hot topic. Okay, we go to the next question. Assalamualaikum doktor. Saya dah beberapa kali masuk ward. This from a patient, Dr. Sazwan. Disebabkan oleh unstable angina. Adakah ia boleh menjadi lebih teruk atau menyebabkan jantung tersumbat?
Okey, Tuan, terima kasih kerana bertanya. Kalau kerap sangat mendapat serangan unstable angina, selalunya pihak hospital akan rujuk Tuan kepada pakar kardiologi untuk buat angiogram. Memang betul jika unstable angina tu dia berterusan, dia next step dia boleh menjadi serangan jantung yang teruk lah. Okey.
Ya betul. Okay, kalau boleh pergi jumpa doktor jantung cepatlah kalau dah beberapa kali Encik ni. This is question from Facebook lah, doktor. Most of the question now is from the patient doktor. So the next question now, my father always sakit dada waktu baring. How, doctor? Is it dangerous?
Sakit dada waktu baring? Jangan baring. Tak ada. Okay.
I think it's very important. I think it's. I don't think we can speculate on the cause of the chest pain just by saying that. It sounds positional, but I think it's dangerous to speculate on the cause. Saya sarankan pergi jumpa doktor dan buat penilaian yang lanjut lah untuk buat untuk dapatkan sejarah perubatan dan pemeriksaan yang betul untuk menentukan sebab kenapa ada dapat sakit dada tu.
Okay.
Terima kasih kepada yang bertanya tadi tu.
Yeah. Okay, next question, doctor. I think from a patient also. Doctor, does high cholesterol in the 20s can lead to heart disease in the future?
Yes.
Yes, it's true.
Itulah jawapan saya.
Yes, it's very true. Okay.
Lepas tu masalah dengan ni nak tambah sikit lah kan. Selalunya orang bila tahu dia ada high cholesterol, dia punya denial tu level dia lain macam lah. Maksudnya kalau doktor dah nasihatkan untuk makan ubat anti kolesterol, percayalah, maksudnya peluang untuk tuan-puan dapat kolesterol normal balik dengan kawal makan tu sangat susah lah. Sebab kalau tak, mesti doktor dah advise untuk kawal makan dulu. Dan mereka pun, doktor pun selalunya dia tengok gayanya macam tak boleh ni. Selalunya kita dah cuba. So kalau bila doktor advise untuk start ubat anti kolesterol tu, mulakanlah. Sebab banyak pasien yang kolesterol ni satu benda yang dengan serius lah. Satu benda yang serius.
Okey.
Yelah lagi tak tahu kenapa ramai yang takut nak jumpa doktor sebab takut tahu ada high cholesterol dan takut kena makan ubat. Tapi sebenarnya kita nak mencegah daripada komplikasi itu berlaku, dan salah satu komplikasi yang boleh berlaku ialah serangan jantung lah kan. Jadi lebih baik untuk rawat masalah kolesterol tu lebih awal daripada kita dapat komplikasi nanti. Dan in fact kalau misal kata kolesterol tu selepas mulakan dengan ubat, kalau misal kata satu hari nanti dengan pemantauan kolesterol tu lebih terkawal, mungkin akan dikurangkan dos ataupun mungkin boleh diberhentikan buat sementara waktu untuk tengok kalau diet control kan, kontrol melalui diet tu boleh membantu untuk mengawal, dan mungkin tak perlu ubat selepas tu, tapi perlukan pemantauan doktor. Dan yang penting macam Dr. Sazwan cakap, jangan takut jumpa doktor. Banyak di luar sana tu yang ada banyak denial kan, ataupun takut nak jumpa doktor hanya kerana takut dimulakan ubat, padahal kita nak mencegah komplikasi yang lebih teruk pada masa akan datang.
Sazwan, from your experience, what's the youngest MI that you've seen?
21.
21. Yeah.
21. My colleague pernah jumpa yang 19 tahun. Tapi yang 21
Dr. Sazwan, soalan yang paling penting, dalam yang muda tu mereka merokok tak?
Kebanyakan pesakit saya yang mendapat serangan jantung, daripada 10 tu 9 dah merokok. Daripada 10 tu 9 merokok. Dan kebanyakan orang muda yang kena serangan jantung tu memang perokok.
Betul.
Dia sedih bukan sebab apa, sebab dia orang muda lagi, kadang-kadang datang dengan anak kecil, yang isteri muda, lepas tu dapat serangan jantung yang teruk. Kita pun rasa lah, sebab kita pun ada keluarga kan, kita pun rasa bersalah jugalah.
Dan betul tak Dr. Sazwan, ni serangan jantung ni mula-mula je, lepas tu boleh ada komplikasi juga kan?
Betul. Okay, bayangkanlah kita kena STEMI ataupun serangan heart attack tu pada usia muda, dan apabila kita berumur 50-60 tahun, kadang-kadang tak sempat 50-60 pun, umur 40 tahun pun kita dah mula mendapat lemah jantung. Jalan sedikit pun dah letih, naik tangga 1-2 pun dah letih. Sayanglah, sebab muda-muda lagi dah banyak benda yang tak boleh buat. Tak boleh nak jogging, tak boleh nak marathon macam Dr. Rafida.
Betul. Okey.
Tapi yang tak sakit pun tak marathon juga ya?
Itu jangan ditanyalah doktor. Ada masa kami sibuk sikit doktor. Okay. So we go to the last question doktor. Last question from the patient I think. Hi doktor, saya nak tanya, saya memang kerap mengalami chest pain. Tiap kali buat ECG normal. Dalam situasi ini, adakah perlu buat check up seterusnya?
Ini saya sarankan ada beberapa keadaan apabila anda alami, jangan pergi ke klinik, terus pergi ke Jabatan Kecemasan. Kalau saya tak boleh nak cakap apa yang penyakit yang tuan ataupun puan ni ada, tapi bila ECG normal kerap chest pain tu, dia dah bunyi macam ke arah unstable angina dah tu. So kalau boleh ketika sakit dada tu terus ke Jabatan Kecemasan.
Okay. Thank you very much Dr. Sazwan for the fantastic presentation. Okay, now we go, I get lead the floor to Dr. Hafsah again. Thank you very much.
Thank you, Dr. Is, for moderating the Q&A session. And thank you for all the excellent questions. I agree, your talk was awesome, Dr. Sazwan, and I'm sure a lot of people benefit from your talk. I know, as I said before, this is targeted for medical practitioners, but we know there are a lot of members among public who joined us, and I'm sure they learn important lessons from your presentation today. And dan sebagai satu pesanan macam kita cakap tadi, pastikan jika ada sakit dada, dapatkan penilaian daripada doktor, berjumpa doktor untuk mendapatkan diagnosis. Jangan diagnose sendiri dan jangan takut untuk jumpa doktor untuk dapatkan diagnosis sebab kita nak mengelakkan komplikasi. To all medical practitioners out there, take all chest patients, pain patients seriously, and make sure you perform a proper clinical assessment, including clinical history and examination to determine the cause of the chest pain. As we have always stressed, common things are common, and the most important thing is to exclude life-threatening conditions when you're dealing with patients presenting with chest pain. And in emergency conditions, for all junior doctors, remember, in emergency conditions, please call for help, okay, no matter what, because we need all the seniors to be on board because there are decisions that have to be made within minutes, okay, in order to save patients' lives. So, is there any other burning questions that we may address just before we finish the session for tonight? Dr. Sazwan, do you have any like few words to say to all medical practitioners and dan kita punya penonton di luar sana?
Okey, lagi sekali sebagai saya mengambil kesempatan ni lagi sekali lah untuk mengingatkan sama-sama kita lah, chest pain ni, bila seorang pesakit mendapat chest pain adalah satu benda yang sangat serius dan kita tak boleh teragak-agak untuk bertindak, tak boleh tunggu-tunggu, okey, sebab dia adalah perkara yang boleh menjadi life threatening dan kadang-kadang sebab kita terlewat 10 minit, 20 minit, nyawa pesakit kita mungkin terancam. Itu saja pesanan saya.
Terima kasih Dr. Sazwan, dan saya nak ingatkan balik semula yang masa perbincangan tadi kita dah ada dapat perkongsian daripada Dr. Sazwan yang kita sebagai doktor dan petugas kesihatan di luar sana, kita dah banyak nampak kes nilai kes yang mendapat serangan jantung pada usia muda, dan kebanyakannya memang adalah perokok. Jadi antara benda yang kita boleh belajar daripada presentation hari ini ialah untuk berhenti merokok kepada perokok di luar sana, sebab ini penting untuk mengelakkan komplikasi serangan jantung dan sebagainya pada masa hadapan. Okey, sebelum saya habiskan sesi pada malam ini, I would like to remind all of you that the next CME session for Sunday next week will be delivered by Dr. Nurul Yakin. She's a consultant respiratory physician, and she'll be presenting on basic interpretation of lung function tests. So to those of you who are interested, please do join us. Same day, same time next week. And I bid you farewell for tonight, and we'll see you next week. Assalamualaikum.